So good afternoon, everyone. Welcome to Wonderful Wednesday. Today is Cardiac Day, and I'm going to talk about STEMI. Only you can decide. And to really focus this topic on evaluation of EKG, troponin, patient history, and patient presentation, and how we bring that all together when we're trying to make decisions about what's going to occur next for patients. So I do always like to introduce this to remind everybody that I do this every Tuesday and Wednesday. I am no longer doing it on Thursday, but I'm always looking for topics, and I'm really grateful if you can send me some topics that you might be interested in. You can send it to me via email. My email is right here, so that I know what you'd like to hear about, and if I'm able to do it, I certainly will. I definitely need your brain trust because I'm running out of ideas. I have now 94 virtual video snippets on my website, which is on my YouTube channel, and my handle is Barbara McLean Critical Care. So I invite you to join that YouTube channel as well. So I want to make things really simple. So I'm going to base them down to the simplest strategy, the easiest way in which we can look at information. Yes. So folks, I will be very happy to send you a PDF of my PowerPoints. I'm also happy to put that in the chat room. That'll be at the end. But if you need the PowerPoints in a PDF, if you ask me here, I will not remember. You need to send me an email to ask for the PDF for the particular talk, and I'll be very happy to share it. So I do want to remind you always, when you're evaluating EKG, to just try to have some simple things. First of all, when you look at V1 and you look at V6 on your 12-lead EKG, really important to say when you look at V1 and V6, always look and say, is there a normal electrical direction? And the normal electrical direction, the common direction, is to the left heart. What that means is that in V1, the primary direction will be downwards, and in V6, the primary direction will be upwards. That's the first thing you have to look at, and that's pretty simple. Is it down or is it up? V1 should be primarily down, V6 should be primarily up. The next thing we're going to look at is the voltage of our EKG of the R wave. Is the R wave taller than 10 boxes? Or is the S wave, which is the downward wave, deeper than 10 boxes? And then, of course, we're going to look at the normal time. And the normal time should mean from the beginning of the QRS to the end, less wide than 0.12, which is 3 boxes. And that should be true in both V1 and V6. And then the last thing that we're going to look at, of course, is looking at normal R wave progression. We're going to talk a little bit about that. And of course, not mentioned here because that'll be the major focus of our talk this time, is there ST segment elevation or depression? And how are you going to quantify that and how you bring that all together? But these really simple strategies help us to evaluate the EKG and hopefully rule out conditions that can cause ST segment elevation without being a STEMI. All right, so I'm going to start off with this patient. This patient was in the 7K South CVICU just last week. And this was her first represented EKG done on 10/10/2022. So if we take a quick look at this EKG, really important to think about what I've said. Is the primary direction V1 down? Yes. Is the primary direction in V6 up? Yes. So, okay, great. Is the down less deep than 10 millimeters? So that would be 10 small boxes in a standard signal. And the answer is no, we're much deeper. We're 5, 10, 15, 20, 25, about 28 down. That's completely abnormal. Now I'm looking at 28 down, and then I'm going to go over here to V5. It's not significantly tall, but we're going to say it's around 6 and 3, about 9 tall. 9 plus 28 is 37. And criteria for hypertrophy, and particularly for left ventricular hypertrophy, is the S wave in your right-sided leads, V1, V2, V3, added to the R wave and the left side of the leads, V4, V5, or V6, should be greater than 35 millimeters. And that's a really basic standard. It's not the only one. There's lots of standards, but greater than 35 millimeters of mercury. So the direction is going to the left, and there's a deep S on the right side and a relatively big R on the left side. This is a very large voltage EKG, which tells us that we have ventricular hypertrophy. Now, the next step is to look at how wide, and it's just about 2.5 boxes here, and it's 3 boxes here. So I'm going to say that it's around 0.12, which also makes me think that there is a delay in the conduction. And because the directional current is to the left, I'm going to say that the patient has a left bundle branch block and left ventricular hypertrophy. Now, why is that important to us? That is because with left ventricular hypertrophy and or left bundle branch block, you will almost always instill ST segment elevation in V1, V2, and V3. Now, that's common with LVH. It's common with the left bundle branch block. It's also common that this is going to get called a STEMI, that the cath lab team is going to get activated. And you can see that we are at 10:30 at night, right? So the cath lab team's not here. They're all home. They're getting rest to come back tomorrow morning at 6 a.m. And if we're not cautious, if we don't actually evaluate this perspective for what we think is occurring for the patient, we might activate a STEMI alert, which calls our cath lab team in for a patient that may or may not meet criteria for STEMI. So by the way, if you're a nurse practitioner, you're a surgical doctor, you're a medical doctor, you're not a cardiologist, you would call this EKG diagnostically uncertain. And prior to activating a STEMI alert, you would actually call a cardiologist, phone your friend, the cardiologist, make sure this EKG has been loaded into TraceMaster, and have the cardiologist look at the EKG. Leave that final decision on them because they are much more sure about evaluating the EKG. Now, there are some other things that are really important here, but when we just take our very first look, we can say, oh, we've got ST segment elevation. This is also called a convex ST segment elevation, which is not typically associated with the STEMI, which makes me think right away, this is probably not a STEMI. And we're going to learn more about this patient. We're going to take a look at a couple of EKGs that occur in serial, not rapidly in serial, but over days' time. Now, very important to recognize that if the patient is presenting with chest discomfort, if their troponin is elevated and you have uncertainty, the first thing is call a cardiologist, but the second thing is repeat that EKG in 15 to 30 minutes. Now, we do a really nice job in management overall, but something we don't do very well is actually serialization of EKG. So if the patient has chest discomfort and or their troponin is their initial troponin is elevated, we should always do a serial EKG. Now that means that you're calling the EKG tech a lot. They've got a lot going on. They're down in the ECC. There's lots of STEMIs in the house. That's one of the reasons it's really important, especially on high-risk areas, that we have an EKG machine and everyone knows how to use it, how to load the EKG, how to notify the cardiologist that we have an EKG that needs to be looked at. But for our first step here with this patient, we're going to say, we're kind of worried about the patient. It looks like she's got a left bundle branch block. Looks like she's got left ventricular hypertrophy. This ST segment change in V1, 2, and 3 may indicate to us that our patient is having a STEMI. She has ST depression in V3, 4, and 5, which is not at all unusual with left ventricular hypertrophy and left bundle branch block. So we don't want to get all wound up about it because we need to appreciate that that occurs with these depolarization deficits. And in addition, we see that in the inferior leads, 2, 3, and AVF, our patient has ST segment depression. Now, one of the most important things when you see ST segment depression, because you're saying, is that a reciprocal change? Or is that non-STEMI ST depression? So first and foremost, you make sure that the T wave is upright. If the T wave is upright, it's unlikely that this is a non-STEMI, but it could still be reciprocal changes to a myocardial infarct, and it just could be representative of the left bundle branch and the left ventricular hypertrophy. So although I'm looking at this EKG and I find it relatively concerning, I would actually not activate a STEMI, but I would call a cardiologist to look at the EKG and rule it out. Okay, so sorry, here's our second EKG. Whoops, sorry. Here's our second EKG, and I really wanted that to be bigger and then to make it smaller so you could do a comparative analysis. And you can see that it's very much like the first EKG. We really haven't had many changes in the EKG, and this is actually 20 minutes or 15 minutes later. Not much change in the EKG, looking pretty good in terms of correlation. Nothing has really changed, nothing that's making me profoundly worried at this moment. And then I'm going to fast forward to this EKG, which is done on the 19th, so 9 days later. Okay, well, now there is significant change, right? And that significant change isn't really in evolution of a STEMI, it's in a decreased voltage of the myocardium. Okay, so I don't really feel that this EKG itself is telling me that the patient had a STEMI, but what I am seeing in this EKG is a profound and significant decrease in the voltage. So just going back, look how big the voltage is here and on those right-sided leads, and how big the voltage is on the left-sided leads, even in the face of a bundle branch block. Got pretty good looking R waves, etc. And then we go to this EKG. The voltage is significantly smaller, and I'm seeing very low voltage as I'm looking at my patient's EKG. So I'm concerned now. My big concern is, are there electrolyte abnormalities? Does this patient have pericarditis? Does this patient have a cardiac tamponade? Or does this patient have a hemothorax? So the EKG is going to give me a lot of information, but it's never enough information for me to truly diagnose the patient in these situations. And if I am solely relying on my EKG, I'm going to miss lots and lots of problems. So I want to remind you about how worrisome acute myocardial infarction is. Of course, we know it's a leading cause of death, and that 42% of deaths from cardiovascular disease occur from an acute myocardial infarction. Men are at higher risk than women, but women present in gentler ways. They don't come in, oh, it's the big one. Oh, I've got this terrible elephant on my chest. They come in saying, I'm really tired. I'm nauseated. I've been sweaty. I'm exhausted, but I can't sleep. And when I lay down at night, my heart rate goes up and I feel short of breath. Women present very differently than men, and we have to pay a lot of attention to that. And it is really important to also appreciate that race is a contributing factor. African-American men and women are more at risk than Caucasian men and women, not just because of inequity, which is also, of course, true, that you're a Black woman who comes to the ER, you may not get the same attention as a Caucasian woman who comes to the ER, but also just genetically, historically relational to diabetes and hypertension. We can actually see that those individuals may be significantly more at risk. Okay, so just remember, when we talk about a STEMI, what is vital to understand about a STEMI is that back in the good old days, I really hate to say that, but initially, when we would talk about myocardial infarction, we would say you have enough damage that is through the whole ventricular wall, from endothelium through myocardium to epithelium. It's called full wall thickness, also referred to as a transmural myocardial infarction. Now we just say STEMI. And it still means the same thing. It is a full thickness from endothelium to epithelium through the myocardium, which actually then creates such a profound disturbance in both depolarization, making the R wave smaller or developing a small downward known as a Q, and also presenting with an unusual voltage charge between the area that is infarcted or injured or ischemic, and the healthy tissue. And that's what gives you ST segment elevation. Now that ST segment elevation will be in the leads that are directly over the area where you have that full wall thickness. You'll have ST segment elevation because all the other cells have depolarized and they have a charge of about +5 to +10. But the ischemic or injured tissue is around -10. And so the current goes from healthy to unhealthy tissue, and it gives you an ST segment elevation. It's big enough that when I put leads on the opposite side of the heart, I'm going to see ST segment depression. So depression plus elevation in opposing leads. So I could say in leads inferior and lateral, inferior and lateral, anterior and posterior, those will be oppositional or reciprocal changes. ST segment in the area where the injury is occurring, and ST depression in the opposite area. But we have to be careful about it because we can also have patients who are having a STEMI with some extension into a non-STEMI area. So again, we're going to be pretty careful. And the most important thing is for us to identify the STEMI. It is really, really important to remember how vital the time is. So I just love this fantastic article from Thigesen, who was in the Journal of the College of Cardiology, which was actually looking at the progression of cell death, right? So you might have an occlusion, and it could be 100% occlusion, but you still have a little bit of time for your cells to survive. Now, some patients who have occlusive disease that's occurring over time, and now they have a plaque rupture, they have a clot, now they have full occlusion. But if they've had some occlusion occurring over time, not just acutely, but the past 6 months, I've noticed that I'm more tired, I'm more fatigued, I'm short of breath, I sometimes have a little chest discomfort. Over that time, hopefully I got diagnosed, but even if I didn't, I'm actually popping open alternative circulation. That's the collateral circulation. So that's fantastic because that collateral circulation will protect me from aggressive cell loss. But if I have a small plaque development or an outpouching plaque lesion, and I rupture the endothelium, which is of course what happens, and what happens is coagulation initiates, and now I have 100% occlusion. So I went from being very limited disease to having an acute 100% occlusion with the clot. I don't have time for collateral circulation. It doesn't develop rapidly. So I'm going to start to have cells that die, and those cells are going to die pretty quickly. At around 30 minutes, you will start to see a penumbra, a central area. That's the penumbra of myocardial infarction, irreversible cell death. And around that area, of course, is an area of ischemia, and around that is an area of injury, and around that is an area of ischemia. And we define that by ischemia, ST segment, injury, T wave, and infarct, the change in the voltage of the R wave or the development of a new Q wave. So really important in terms of how I'm looking at an EKG. And these are just really simplified ways for us to think about this. So start having that myocardial death. And once that begins at around 8 minutes, you will start to necrose your myocardium. So this is why it's so incredibly important to be suspicious when you see patients in the emergency department, when you see inpatients who are having any presentation that makes you concerned, you need to be suspicious. And if it's something you don't feel capable of diagnosing, or you feel like your primary teams are not really listening to you, you need to escalate, because quite honestly, every delay of a minute can actually lead to significant loss of the myocardium. So when you first see a patient, you think about two really big things, right? What's the patient's history? And that's the patient is going to define that for you. And when you're looking at them, does it seem, this is very subjective, does it seem like this is a cardiac presentation, reminding ourselves about diabetics who present differently than non-diabetics? African Americans who present differently than Caucasians, women who present differently than men. And you really do a disservice if you're putting everybody in a Caucasian male venue, which is traditional chest pressure, radiation down the left arm. The other patients can present that way, but it's much less likely in that non-Caucasian male population. So we have to open our minds in terms of how we're going to evaluate the patient. And of course, as soon as possible, we're going to do an EKG. Now, the EKG is not definitive, but really even more important than that is, by the way, very first thing, if you have the capability, a point of care troponin. Hold on one second. I'm fine. I'm sorry, I'm on a web call, but thank you. Everything is good. Thank you. I'm in a hotel room, so they're so lovely. They're coming to clean my room, which is already clean, and they're very nice. They said, "How are you?" Okay, so really, really important when we're thinking about this presentation is really trying to categorize it and getting that EKG, which may or may not have changes, but really important is point of care troponin if you have the capability. And if you don't have point of care troponin, you should do a point of care if you can, immediately followed, and mark your clock by your first HS troponin. Now, something I want to remind you about with HS troponin is you draw your first HS troponin. We're down in the ER. You draw your first HS troponin immediately after you do a point of care. You're not waiting to get all these results, and you mark that clock. So I drew your first HS troponin at 9. It's not resulted at 10, but you have to draw that second troponin 1 hour after the first troponin because you're looking at rate of change. That's actually going to tell you if your patient's having an acute event. If you're in hospital, typically what you're going to do is you draw your first troponin at hour 0, and then you're going to follow that at hour 3. And again, it's not 3 hours after I got a result. Oh, I thought about it. Let me go do it. Really, you have to make a commitment to this HS troponin to draw it in a timely manner. You didn't get the result from the first one, you're already drawing the second one, because by the time that second one results, you are already 2.5 to 3 hours into your process. And remember, your myocardium is already dying at 30 minutes. So we need this to happen quickly. Now, if our first troponin is elevated and we have EKG changes and the patient's story seems really significant, and we think this is a presentation for an acute myocardial infarction, we're going to activate the cath lab. If we're not sure about the EKG, but we have an elevated troponin, the patient's story is pretty significant, probably also going to actually end up going to the cath lab. But in this case, you're going to call the cardiologist. So you're maybe not going to make that decision till you've spoken to the cardiologist because you don't have any really strong EKGs. Now, let me tell you that over the last few weeks, we've had a lot of patients who haven't had much EKG change, who are infarcting their whole heart. We have people who are having big EKG changes that are really not infarcting. This is really critically important because I can say for certain, I think we've had a few patients who might have done better had we been more aggressive and more activating on the patient on initial presentation. So just going to remind ourselves, do I think this is a STEMI? Does it look like a STEMI? Does it sound like that? Based on understanding how patients present, what's that patient's history, and doing an EKG and troponin level. That's my big bundle. That's my big package. I'm looking for ST segment elevation. I hope I see it because that's really definitional in 2 leads that are next to each other. That's called the contiguous leads. And then I'm going to look, if it's possible, at reciprocal changes, which means opposite changes on the opposite wall. But really, the only true reciprocal changes you actually evaluate are lateral and inferior. So if I have ST segment elevation in the inferior wall, I expect to see ST segment depression in the lateral wall, and the exact opposite. If I have ST elevation in the lateral wall, I expect to see ST segment depression in the inferior wall. I don't really have any other absolute reciprocals. I might see ST segment depression V1, V2, V3. That's completely abnormal. That should never happen. That's generally reciprocal for the posterior wall. But unless you put leads on the posterior surface, you're not going to know that. So it used to be in the STEMI alert for the American Heart Association. all about reciprocal leads and you've got to have reciprocal changes. And then it's like people like me write to them and say, what about all the leads that don't really have reciprocals? We're actually creating a problem when we tell individuals they must have reciprocal changes. You're going to look for reciprocal changes. And if it's inferior and lateral, you need to have reciprocals. But if we're talking about the anterior wall, you might not have any reciprocals. If we're talking about the posterior wall, the only thing you're seeing is the reciprocals. So it's really important to put that into a good framework in terms of how you're deciding if a patient has the possibility of having a STEMI. So a couple of things that are really important is the description of the patient's history. And so I always like to say the difference between unstable angina, non-STEMI, and STEMI, okay? Unstable angina basically means that I have chest discomfort that has not been diagnosed by a professional. Aunt May, who has chest pain, who told me it's chest pain and gave me her nitro, that's not good enough.